Here in Chapter 3 of Radiography of the Small Intestine, I'm going to continue talking about obstruction of the small intestine with a specific focus on linear foreign bodies, and then kind of finish off this chapter with just kind of some more general discussion on considerations in cases of obstruction, or at least suspected obstruction. A linear foreign body is a subset, obviously, of the general foreign body class. They act a little bit differently than some more conventionally obstructive foreign objects because one end of this linear structure becomes fixed in the proximal portion of the digestive tract, the rest of the foreign object passes into the small intestine, and then peristalsis of the small intestine causes all the GI tract to bunch up into what is called a plicated shape. And so the small intestine ends up looking a bit like an accordion, and radiographically that can have a number of different appearances, but one thing that you will see is an abnormal shape of the intraluminal gas. So normally gas bubbles are in the center of small intestinal segments, and they're relatively round or oval or maybe kind of linear, but here they're much more oddly geometric. Teardrops, comma-shaped triangles, any sort of unusual, not particularly round shape goes, and they're often a little bit more peripheral to the overall diameter of the small intestine than we'd normally expect. Most foreign objects themselves are more soft tissue opacity, so we often don't see the object, we just see the effects in that there's that odd shape of intraluminal gas and the small intestine looks really bunched. There can be intestinal dilation, but it's usually not particularly severe, so usually it's not to a degree that you'd start talking about two populations of small intestine, although it can be. When dogs get linear foreign bodies, usually what they eat is something made of cloth, and it's usually long strips of that cloth. So it could be carpet, it could be towels, anything like that. The structure itself is a soft tissue opacity, so it can make it hard to see, although usually there's gas kind of in the midst of it, and so you will see kind of a streaky mixed gas and soft tissue opacity structure to clue you in. The proximal end of the foreign object is usually lodged in the stomach, usually in the pylorus. So you got this wad of cloth in the pylorus, and then the rest of it tracks down into the duodenum and the rest of the small intestine. With cats, usually they're eating a lot thinner string-like objects rather than thicker cloth-related stuff, and so we almost never actually see that linear foreign body just because it's so thin on radiographs, and that type of foreign object tends to get stuck in the mouth. At the base of the tongue is the most common spot, and then the distal end of the foreign object again travels down into the stomach, down into the small intestine, where it results in plication. So here schematically you can see what it looks like in a dog, where we have this linear structure, again probably some sort of towel or something like that, where one thicker end of it gets lodged at the pylorus, the longer skinnier end travels down into the small intestine, and then as the small intestine continues to contract with its peristalsis to try to pull that linear object through the GI tract, the linear object is anchored, so it's not going anywhere. So then rather than the contractions of the small intestine pulling the object down, they actually manage to force the small intestine to climb up the object itself. And so what that looks like is something like this on radiographs, where normally, again, in the pre-plicated state, you're going to see soft tissue / fluid opacity in the lumen, maybe a nice smooth gas bubble, but then with plication, the gas collects in these odd outpouchings and bunchings of the small intestine, and so you get these weird, eccentrically located and oddly geometric triangular teardrop-shaped gas bubbles. And here's what that looks like on an upper GI series, a very bunched small intestine through here, harder to appreciate some of the gas bubbles just because there's uneven filling generally, but very weird bunched plicated shape here. Here's another example, again, an upper GI series. You can see that there's some degree of distension of the small intestine, so it's not a normal small intestine anywhere, but then you can definitely see the loop that's most affected, or loops that are most affected, where all the GI loops, all the intestinal loops are bunched together in this kind of plicated accordion-like structure. How much plication you see is going to depend on a number of things, exactly where in the small intestine the effects are, what exactly the object is, how long it's been there. One thing to note is that the duodenum won't become as bunched as the jejunum does, because it has an attachment to the body wall. So the mesoduodenum, it's a band of connective tissue. It kind of anchors the duodenum mostly in place, and because of that, it really can't squeeze itself up and accordion up as much as the jejunum can. The jejunum has mesentery, but it's very flexible and movable, so the jejunum will become a lot more plicated with a linear foreign body. A vomiting dog is probably going to have a linear foreign body. So what I see here is that you've got pretty nice serosal detail through most of the abdomen, a really distended stomach, and then multiple small intestinal segments that are pretty markedly distended, some others that are quite small. Too much intestinal dilation to all be large intestine, so at least a good portion of this is small intestine, and it's certainly abnormal. You'll notice that the shapes of the gas bubbles are also pretty irregular. Some teardrops up there, so this would be concerning for plication and thus a linear foreign body. Again, you can see that there are some normal ones, so we have two populations of small intestine indicative of an obstruction, regardless of linear or otherwise. Same dog, other view, giant distended stomach, variation in size, and then odd gas bubble shapes. It's a little hard to see. I changed the contrast here, but up in the area of the pylorus and leading into the duodenum, you can see this heterogeneous material. So this is the cloth that this dog had eaten, resulting in the plication downstream. As I've mentioned previously, cats will have, quote, bunching of the small intestines in the right midventral abdomen, especially if they're fat. So you have to be careful about saying bunching or a collection or accumulation of small intestine as a finding in linear foreign bodies, again, because that is very often normal in cats. You really need to look for the true plication and not just collection of intestines. So this is a normal fat cat. Again, you see that all the intestines are gathered in one spot. That's not plication. Plication is when they are truly irregular, like an accordion. These are collected in one place. And here we go on the VD view. They're collected in one place, but you can see that the shapes of the intestines are normal. They're kind of relaxed. They're gradually sweeping from one area to another. They're not, really crammed together. So this is normal. And that leads us to this vomiting fat cat, which also does have a collection of small intestine in the midventral abdomen. But these are not normal in their appearance, in that we have very odd shaped gas bubbles. They're irregular. These are not relaxed and sweeping back and forth. These truly are crammed together. These truly are plicated. So this cat then has a linear foreign object. Here we see it on the ventrodorsal view. Same story. The position of the intestines is not what troubles me. It's the fact that they are really not relaxed. They're really wadded on each other. The gas bubbles have irregular shapes. So again, this is going to be a linear foreign object. So when we talk about general mechanical ileus, kind of now putting all the different foreign objects together along with intussusceptions and anything else, we know that radiography isn't always the definitive answer. So what choices do we have after we've made radiographs and we're concerned at some level, but we don't know what the final diagnosis is? One thing to do is go back and look at the patient again. Remember that we have to put all of our findings together, from radiographic findings to other imaging findings to lab work findings to clinical picture overall, and ultimately you have to decide what you want to do with that collection of information. And we know that with any test, accuracy is not going to be perfect. So there are going to be false negatives, there are going to be false positives. So for example, pancreatitis in a dog can look like a proximal small intestinal obstruction because there's going to be some dilatation of the small intestine around that pancreas. And that can give the impression of two populations of small intestine. If you go to surgery for that dog, you're not going to find anything. That doesn't mean it's wrong to go to surgery, but you have to decide what you think the likelihood of obstruction is based on all of the findings, both radiographic and non-radiographic. You also have to decide, how long can you wait for a given patient to decide what you're going to do next? How long can you wait before you go to surgery? How sick is the dog? Do you have other tests available? Do you have a sonographer who you trust to do ultrasound on this patient and confirm or rule out a foreign object or is it going to be 4 days before they can get here and you're better off exploring right now? So, there are a lot of different considerations in real life as to what next steps might be. If ultrasound isn't readily available, then an upper GI series is probably a good bet if radiographs are inconclusive. But on the flip side, it can take a few hours to get an answer with an upper GI series if it takes that long for the contrast medium to get to the site of obstruction. So you always have to weigh the pros and the cons of any potential next steps. Exploratory laparotomy is an option. If you have reasonable suspicion that there is an obstruction in a patient and radiographs are inconclusive, exploratory laparotomy can be both diagnostic and therapeutic. But there is still a risk of a false negative, and while some false negatives are okay, you don't want to be willy-nilly going to surgery on every patient. So you have to decide how sick is the patient, what is the availability of other testing, is the client willing to take the financial risk of going to surgery versus the financial risk of not, and spending days in the ICU, and then obviously the morbidity associated with surgery or not going to surgery. Repeat radiography is fairly easy to do. Again, it implies that you're going to be spending some time waiting before you take the next set of radiographs, but it can give you an answer, although it doesn't always. Sometimes you're left with the same information that you had after the first set of radiographs. But it can be useful to evaluate if things are going in the right direction or the wrong direction. Is small intestinal distension getting worse, or is it improving? Is there foreign material in there that we couldn't see before that maybe now we can? Or if there is potential foreign material, is it passing? So all of these things can be useful whichever direction they're going. So here we have a cat who's been vomiting. Nothing is profound, I think, in this cat. The stomach has some gas in it. It's a little distended. It's not the biggest stomach I've ever seen. The small intestine isn't particularly exciting. It's really nonspecific here. Again, their stomach, it's not that dilated. None of the small intestine is overly dilated. So I don't have an answer yet. And so I've got a lot of options as to what I can do next, all the way from nothing and medical management to further radiographs to exploratory laparotomy. My final choice is going to depend on what the patient's clinical signs are. This would be one, given the relative lack of distension. Medically managing for enteritis is probably a good starting point, but then depending on how the animal does, consider radiographing again in a few hours to see if anything's changed. Obviously, if the patient's doing well clinically, maybe I'm not going to re-radiograph, but if there's any question if he's not improving or if he's getting worse for sure, then repeat radiographs would probably be a next step. So this cat continued to vomit, and 6 hours later we re-radiographed the cat, and now things have changed. The stomach is huge, mostly gas-filled, although there is some fluid here ventrally on this view. The small intestine remains relatively unexciting, but there has been a pretty substantial change in the stomach, and as I mentioned before, there is that disconnect between stomach and small intestine. If the stomach's so big, why is nothing getting into the small intestine? Is it that the stomach is just functionally stopping, or is there actually a mechanical issue, some sort of relatively proximal obstruction, whether that's pyloric or whether that's proximal duodenal? Here it is on the VD view. Again, gigantic stomach, real easy to see the shape. Most of the small intestine, not that exciting. So again, I have to be concerned about an obstruction here. It's not a slam dunk. Pancreatitis could do this. Certainly other functional issues where the stomach is filling and just not emptying, but obstruction has to be reasonably high on my list of differentials. So now I have to figure out what my next step is. Now that my concern has increased, we could definitely go straight to exploratory laparotomy. We certainly have other imaging tests that we could do before we get all the way to laparotomy. Again, it just depends on what's available and how sick the patient really is. On this one, we ultimately did an ultrasound first and found a foreign object in the duodenum, which then we knew it was time to go to surgery. But any of these other things would have been potentially reasonable. A left lateral radiograph might have shown us the object if it surrounded it with gas. An upper GI series probably would have demonstrated an obstruction. Or based on the changing in the radiographic findings initially, compared to the more recent radiographs, doing exploratory laparotomy would have been reasonable as well. So again, we had options, and any one of them would have been appropriate potentially in this case. An upper GI series is always a useful test when survey radiographs don't demonstrate definitive distension of the small intestine, but you're still concerned about that possibility, either because there's a really proximal obstruction or because there's only a partial obstruction, and so there's not full distension of the small intestine. Upper GI series are also really useful for allowing you to evaluate the mucosa of the GI tract, ulcers, masses, thickening, and then look at transit through the intestine as well. Every now and then, the upper GI series will be therapeutic. It can actually cause the foreign material to pass. If nothing else, that barium will coat any ulcers and erosions, and that can help the patient feel better from a gastroenteritis sense as well. There are, of course, limitations, as always. One is that if the patient is vomiting all the time, he or she will puke out all your barium, and then you're not going to get a good study, so that can be a problem. And then the study can take a long time. It can take hours before the contrast medium gets all the way to the lesion in question, and so you're accepting the fact that you're going to be waiting a while for a diagnosis, and even if you get a diagnosis, all of a sudden now it's 7 in the evening and you've still got exploratory surgery ahead of you. So here we have a patient who's vomiting. Survey radiographs were normal, other than some distension of the stomach, which wasn't too surprising. So here we have an okay upper GI series. We at least got some distension of the stomach. It's maybe not the most distended I've ever seen. I can see the duodenum coming down. There is contrast medium moving into the jejunum, so whatever this is, it's not a full obstruction, but that duodenum is a lot larger than any of those jejunal segments, and it's kind of interesting that the contrast medium hits this kind of curved area and leaves that as a nice defect in the contrast medium. Again, some of the contrast medium passes around whatever this filling defect is and does move further distally or further ab-orad in the small intestine. As we go to the VD view, we kind of see the similar sort of stuff. Decent looking duodenum proximally, gets distended at this point, kind of in the mid-descending area, and then hits this focal filling defect. And because contrast medium is going all the way around it, at least as much as I can see, I would call this an intraluminal filling defect. It doesn't have the broad base that I would expect from mucosal or mural. And again, it's got contrast kind of creeping around it on either side, both proximally and distally. So it really looks like it's a structure within the lumen. It's not a complete obstruction because contrast medium is getting around. Kind of an additional interesting finding is that there is this kind of accumulation of contrast medium within the center of the filling defect. So there's some sort of hollow nature to this, but yet the contrast medium is able to kind of sneak in there as well. So it's some sort of foreign object. It's in the duodenum. It's causing a partial obstruction, again, because it is causing some distension of the duodenum. And this is a patient who needs to go to surgery. This was a not very good case of an upper GI series in a vomiting dog. Here we can see, you can see we're at 30 minutes. There's no contrast medium in the stomach. It's not particularly distended, but there's also not very much contrast medium in the small intestine. There really just wasn't enough contrast overall, and that could have been that we didn't give enough, but we're usually better than that. So in this case, we gave the appropriate amount, got good distension of the stomach, but the dog vomited most of it up, so very little was remaining in the GI tract to help get us an answer. And so this was essentially, I won't say non-diagnostic, because we can see at least that where there are intestines here, there's no evidence of obstruction and the margins are smooth, so it's not looking that exciting, but it's certainly not a very high quality study, and it's one where we could still miss a lesion. If you can't tell if an intestinal segment is large intestine or small intestine, and it's big enough that you would be worried about it if it were small intestine, doing a colonogram is something that can be both easy to do and very diagnostic. Usually in these cases we'll do a pneumocolonogram because it's a lot easier and less messy to give gas than it is to give barium. So here, case example, we have a vomiting dog. There's some distension of the stomach. Here's the pylorus down here. And pretty readily we can see that there is some sort of round mineral opacity object, maybe some sort of ball in the abdomen. But it's not really clear where that ball is. None of the small intestinal segments are particularly distended, and I'm going to assume that ball is probably in the intestine somewhere. It's unlikely to be free in the peritoneal space, but I don't know if that's small intestine or large intestine. Its location is plausible either way. The VD view isn't overly helpful either, because that's a spot where I might expect to see colon, say ascending colon. It's also a spot where I might expect to see duodenum or even jejunum. So, any of those are still possible. Again, I don't even know if this is the cause of the patient's clinical signs, although if it's vomiting, there's a decent chance of that. So we did a pneumocolonogram. We administered gas into the rectum via a catheter, distended it a bit, and so now anything that is gas should be connected to the colon, at least fairly obviously visually, and we can decide if this structure is in the colon or not. And I can see now the colon. There's rectum caudally, descending colon. There's a little redundancy to it. We get transverse and ascending colon and cecum up here. And you can see that the structure is not within that gas-filled large intestine. And we can look at it on the VD view, same story. We can see where the colon and cecum are, and we can see that this structure is not in one of those structures. So this object is in the small intestine, and given the location, duodenum is as likely as anything. And duodenum is relatively proximal, so that's probably why we're not seeing distension of the rest of the small intestine, because most of the small intestine is ab or ad to the lesion, and so it's relatively empty. I'm not going to talk much about ultrasound here. I'll leave that for other lectures, but ultrasound can be useful for identification of foreign material or other causes of obstruction, but it depends how good the sonographer is, and it depends on how much gas is in the abdomen, or specifically within the GI tract, because the more gas there is, the harder it is to see the stuff that you want to see. So there are definitely some limitations with ultrasound. The appearance of obstructions on ultrasound is going to be pretty similar to that on radiographs. Two populations of small intestine, some empty, some distended with gas or fluid. Ideally, you'll identify the cause, either a shadowing object in the lumen to indicate foreign material, or an intussusception or a mass, but we don't identify the actual cause 100% of the time. Again, most of the time, but not always. And ultimately, we still won't know if the foreign body will pass. So there are some foreign objects that will continue to pass, and many won't, and that's not something that ultrasound is going to let us say. So kind of wrapping up the general thoughts on mechanical ileus, remember that a very proximal or a very distal obstruction may be difficult to diagnose. A very proximal obstruction may not show evidence of dilatation of the small intestine, because most of the small intestine is empty and distal or ab or ad to the lesion, whereas a distal obstruction may look more like a functional ileus, because there's so much intestine proximal to it that nothing has to get all that distended. A few additional points that weren't really worthy of their own slide, but are kind of notable. When you see obstruction at the ileum in an old patient, you need to think about neoplasia, because ileocolic carcinomas are not uncommon. Intussusceptions in old patients are also often secondary to masses, and again, especially neoplasia, whereas intussusceptions in younger patients may be primary or may be caused by inflammation, such as by parasites, and are much less likely to be due to neoplasia. So just because there's an intussusception doesn't mean it's the only thing there, and you always have to consider other potential causes for it. And that will take us to the end of the obstructive talks. Next up is functional ileus.